Rick, because he's one of us. He's here in Washington University in St. Louis, much longer than I've been here. So, how many years?
20.
20 years.
21.
And ongoing, and he survived. So anyway, Rick received his, he's actually a local, not only from Washington University, but from Missouri, because he went to University of Missouri in Rolla, where he did his undergraduate and master's in computer science, and then went to Clemson in South Carolina, where he got his degree in biomedical engineering. And after that, a postdoc with Jack Bourneau, who's also here. And together they came to Washington University, which at that time was very creative and innovative in new procedures for heart surgery, especially the maze procedure for atrial fibrillation. So Rick has been involved for 20 years in research in surgery of arrhythmias, and especially atrial arrhythmias. And so his talk today is related to that subject, and it's something very important. I think you'll probably say, you tell the reason for doing research on inflammation post-surgery, because inflammation post-surgery always, or almost always, is linked to a lot of cases, very common, of atrial fibrillation post-cardiac surgery. And it's being connected now to the inflammatory response post-surgery, and that's what Rick will tell us about.
Thank you very much. First of all, I wanted to thank all the students I got to spend time with. It was really a lot of fun to sit down with some of you today and hear about the research you're doing. It was also very humbling. I kind of feel like the country boy come to the city, seeing all the high-tech stuff you guys are doing, and I really appreciate the time you guys took, and I thank you for spending some time explaining some of the stuff. It was a long time since I've seen some of that stuff, people talking about mesh versus point interpolations and stuff like that, but it's been a long time since I did numerical analysis stuff, so I appreciate everybody's taking their time today. I'm going to talk about a subject today. Let's see if we can get the slides here. No, maybe not. Atrial fibrillation that follows cardiac surgery. And this topic's important not only because it's a huge problem for us clinically, but also I think it gives some insights to the atrial fibrillation that's unrelated to surgery and how inflammation may play a role in that particular arrhythmia. To give you guys some idea of the magnitude of the problem, these are the incidents of atrial fibrillation that occurs after different types of surgery. So even in surgery that doesn't involve the chest, non-thoracic surgery, or things like orthopedic and GI surgeries, it can be about 5% of patients postoperatively will develop atrial fibrillation. And even in general thoracic, in which we don't touch the heart, the incident can be anywhere from 15 to 30%, probably averages right around 15% overall. Cases that involve doing coronary bypass surgery range from anywhere from about 25 to 30%, 35%. This OPCAT, for those of you who aren't familiar with the terminology, is coronary bypass surgery that's done without cardiopulmonary bypass. That is, we don't put patients on a pump. And one of the interesting things of research, people have gone back and done what we call data dredges, looking at the incidence of postoperative atrial fibrillation. One of the more interesting observations that has occurred in the last few years is people have always blamed the pump, cardiopulmonary bypass pumps, for atrial fibrillation. Everybody's assumed that that was where the big problem lied. And in fact, there's very little difference between patients who have their coronaries done off pump versus those who have it done on pump. And so this was actually a kind of a major revelation and kind of dispelled a very common wisdom that was thought of in cardiac surgery. As you do aortic valves, mitral valves, combinations of valves, and coronary surgery, the incidence goes up. But you can see it goes anywhere from here, like I said, about 5% all the way up to over 60% of patients will have postoperative atrial fibrillation. I have two lines on here. In 1993, our incidence of postoperative atrial fibrillation was like in the low 30%. At that time, about a third of the patients two-thirds of the patients we did cardiac surgery on had coronary bypass surgery. Our practice has changed, and what's occurred over the last few years is that now we do a lot less coronary surgery because of what's being done in cardiology and stenting, and we now do a lot more valves, and as a result, we probably do now two-thirds of our cases involve valves or combinations of valves, and only one-third of our patients are simply coronaries, and our incidence is now, as of last year, was 50%. So it's a problem that is significant in that there's a high incidence.
I think so. One out of 2 patients who go into surgery comes out with
in Washington University now, half of them. And this is despite very aggressive therapy using beta blockade, normalizing electrolytes, magnesium, all the latest and newest types of techniques. If you look at the literature in postoperative atrial fibrillation, there's enormous literature. There's actually books that have summarized the data, and the literature falls into 2 distinct categories. The first category is documenting the incidence and the risk factors, which I'll talk about in a little bit, and the other category is all kinds of drug trials in which various therapies have been tried. In all these studies, a lot of them show a difference when using various standard antiarrhythmic therapies to treat this problem, have shown fairly dramatic reductions. Unfortunately, when they're actually used in what we call a clinical pathway, that is, when we give it to patients as part of a standard treatment protocol, that when a patient comes in an intensive care unit, they go into an algorithm where we say, okay, if they have atrial fibrillation, what are we going to do? Well, the first thing you may do is check the electrolytes. The next thing you have to decide if the patient is hemodynamically unstable, are you going to defibrillate or cardiovert, and so on. When these drugs get put in which we take all oncomers into the study, there's no difference between the drug treatment groups versus the ones that haven't been treated. And so, except for amiodarone, if you can preload a patient with amiodarone, there is actually a small reduction. The problem is most of the patients we do operations on aren't scheduled very far in advance. As a result, they can't be preloaded. The other problem is that a lot of patients are intolerant and do not like to take amiodarone. Simply, there's a patient compliance issue, and we've actually abandoned trying to preload patients with amiodarone in our service simply because it hasn't worked. So that's about all I'm going to say about treatment is it just doesn't work.
Well, what about the prophylactic anti-inflammatory?
We'll get to that. Yeah, we'll get to that. Yes.
So this is the WashU School of Medicine data, or is it?
These lines are WashU School of Medicine data. Some of these curves are also from our data. I'll actually show you. These are really somewhat composites of many institutions, but our data parallels most institutions have shown in these cases. Now, there's one exception I don't show on here, which is kind of one of the big clues. You notice as we go up kind of on this curve here, we're going along with more and more complex operations that involve more and more manipulation and cutting and manipulation of the atrium. Heart transplantation, which probably has the biggest assault on the atrium that you can possibly imagine, where it's been cut out, made ischemic, put back in, sewed in, cut in many places, actually has about an 11% incidence of postoperative atrial fibrillation. And I think this is a big clue, because one of the things which you do with a patient who's undergone a transplant is they have a lot of immunosuppression, including a lot of steroids that suppress the inflammatory response. So I think that's one of the first clues that a lot of people kind of have is that the incidence in postoperative atrial fibrillation in the heart transplant group is much lower than you would anticipate. You would expect it to be up somewhere down in here, not in there. Now, postoperative atrial fibrillation has a very interesting time course, also somewhat revealing. Its peak incidence starts at about postoperative day 2, and by postoperative day 5, about 87% of the incidence has occurred. So you can see that there's a very distinct time course. And by day 7, less than 3%, beyond day 7, less than 3% of people have postoperative atrial fibrillation. So it has a very distinct time course. And it's very interesting because, as I'll comment later on, this is also the time course that you would expect to see in inflammation and inflammatory markers in a patient following an operation. Now, the problem is with that, it's not any evidence of a causative effect because it's associative. And I think one of the things we're going to have to do at some point is we're going to have to get to the point that we can decide what's causative. Because if you look at 100 other different variables, physiologic variables, when you do a surgery on a patient, this is a massive assault on their physiologic system. So a lot of things change. So there's all kinds of changes in hormones. The nervous system has all kinds of changes that go on with it. So there's pressure changes in the chambers as a result of a lot of this surgery. So there's a lot of things that go on in addition. And one of the points I want to make is that as we talk about inflammation as a mechanism, I don't want you to walk away thinking that it's the only mechanism. I think it's one of the mechanisms, and we think it may be a significant mechanism, but it is certainly not the only mechanism, and there's a lot of other things going on. So the question is inflammation going to be just associated with this, or is it going to be causative? And why is this of such concern? Because it looks like something that happens after surgery and goes away. Why are we so concerned about it? Well, there's an increase in operative mortality. In fact, there was a more recent study that showed that this number is more like 7%. So there's an increase in mortality. There's an increase in stroke. There's an increase in postoperative ventricular tachycardia and fibrillation. Requires more permanent pacemaker implantation. In patients with heart failure, the loss of their atrial function that occurs when you have an irregularly contracting atria is also significant. It increases your heart failure. It's also associated with an increase in perioperative MI. A huge thing from hospital administrators' point of view, and hospital administrators all know about postoperative atrial fibrillation because you keep the patient in the hospital about 4 days extra, one of which is in the intensive care unit, and this is, of course, very expensive. It probably adds anywhere from $8,000 to $12,000 additional costs, and these are 1996 and 2001 numbers based on inflation in healthcare. Even if you look at these numbers, just coronary bypass patients probably annually add to the cost of healthcare about $1 to $1.5 billion additional cost. So this is obviously a significant factor in terms of healthcare delivery. So what are the risk factors? Well, like just about every other disease, as you get older, there's an increased risk for this occurring as you get older. If you come to the operating room with pre-existing AF, that's obviously a risk factor. But what I'm going to talk to you today about is what we call new onset atrial fibrillation. And that first slide I showed you was new onset atrial fibrillation. Doesn't include patients who already had pre-existing, because unless you do a specific procedure to treat a patient's preoperative atrial fibrillation, there's no reason to suspect he's not going to have it postoperative. And so preoperative AF obviously is, and about 5% of people who come to cardiac surgery have pre-existing AF, at least in our experience. Valve surgery is a big risk. Withdrawal of beta blockers just prior to surgery is a big risk. Withdrawal of ACE inhibitors. And one of the points, I'm not going to make too big a deal about it today, but we've been putting together a grant. It appears a lot of the changes that we see are similar to those that occur in heart failure. When you have heart failure, there's an increased risk of atrial fibrillation and a big inflammatory response. So this is why I said at the beginning of the talk, not only is this important, I think, for this specific surgical problem, but it may have some implications when we look at just atrial fibrillation in the general population, particularly those maybe who have heart failure. Postoperative beta blocker use has been shown to have a positive effect, although in our experience it really hasn't. Like I said, it's put in the clinical pathway. There probably are some subgroups of patients that if we could identify, we would benefit from this. Postoperative use of ACE inhibitors has seemed to have some effect. Clearly one thing it has an effect and is not included in the data I showed you is normalizing potassium levels. the data I showed you was the incidence of atrial fibrillation that occurred after all the electrolytes have been normalized. Clearly, you can get a lot of arrhythmias if you have abnormal electrolytes. And another thing is postoperative non-steroidal anti-inflammatory use has an odds ratio of about 0.5, which shows that there's a reduction with the use of things like ibuprofen. Just patients on ibuprofen seem to have a lower risk. This shows the data with age being the most significant, where you can see, and this is just in coronary patients, this was a study we did, that if you're getting your coronary bypass at age 20 to 30, obviously you've got a lot more things to worry about than postoperative atrial fibrillation, but the risk is very low. But as you get older, and probably our patient population has an average age of about 62 to 63, you would expect them to be in the 30 to 40% range. And as you get older, just like atrial fibrillation in the general population, you have an increased risk. So is there any data to suggest that inflammation is related? There's been some studies out there that have suggested that inflammation may play a role. For instance, there's an association with an increased white blood cell count. There's a significantly greater number of patients who have post-op AF with high white blood cell counts. Increased C-reactive protein levels, which is an acute response protein that reflects the general inflammatory response. Increased oxidative stress. People at the Cleveland Clinic, David Van Wagner in particular, has had some preliminary data that suggests that antioxidant therapy could be beneficial. That hasn't completely worked out. There's evidence there's an association with increased risk of activation of the complement system, and the pro-inflammatory and anti-inflammatory reactions that innate and adaptive immune system also seem to parallel the time course of postoperative atrial fibrillation. So the release of cytokines, both anti-inflammatory and pro-inflammatory, follows the time course that you would expect atrial fibrillation to occur. It's also kind of interesting from the point of view of cytokines that as you get older, for instance, you produce less anti-inflammatory cytokines than you produce pro-inflammatory cytokines. So this whole issue of why there's an increased risk with age may lie also within this inflammatory mechanism. So there have been several studies looking at steroids, and for all the surgery residents in the front row here, they know why studies like this have to be done overseas, because very few human studies committees would allow you to do this, because just giving steroids to patients who aren't being immunosuppressed, you really run a risk of a whole raft of postoperative complications, increased risk of infections, the list goes on and on. But there have been some studies that have been done. This is one study that was published recently, which steroids were given preoperatively and then postoperatively, and there was a rather significant decrease in the incidence of atrial fibrillation in this particular patient population, went from 51% to 21%. Unfortunately, there was no difference in the length of stay, and complications, there were a lot of minor complications, and an increased trend of major complications like sternal wound infection, acute pancreatitis, bladder infections, just a whole raft of nasty things you don't want to have happen. And in fact, there was despite the use of steroids, there was an increased white blood cell count, probably due to an increased infection rate. Although IL-6 was reduced in the patients that did not have atrial fibrillation. So, although steroids here suggest that this is a causative mechanism, this is not a type of therapy that you could routinely give to patients because of all the problems and side effects of steroid treatment. Before I go on to the next part, I want to tell you how I view arrhythmias. And when I think about arrhythmias, I think about 4 substrates for atrial fibrillation. One is a trigger, usually a premature beat or a run of premature beats, and that can be a focal mechanism from abnormal automaticity, after the polarizations, can cause any of these. The other thing I think about the other substrate is the conduction, both the magnitude and how uniform it is. Refractory is both its magnitude and distribution and uniformity, and then the geometry, both the macro anatomy, things like where the vena cava are, the microvalve, annulus, tricuspid valve, annulus, and micro, how the fiber orientation is very disjoint in the atria and how that might affect things. So when I think about atrial fibrillation, these are the four things I think about. So I could give you a long review. In fact, I could give you a complete review about all the basic science work that's been done in postoperative atrial fibrillation. And basically, I just did. There is very little. There's very little that's been done from a basic science level. Nobody's tried to create any animal models. There's been a few studies where people have tried to go in and isolate myocytes from humans and get some data there. But basically, in terms of animal models, there really has not been a good model of postoperative atrial fibrillation. So we set about a couple of years ago to design what we thought would be a realistic model to model the electrophysiologic changes that occur with surgery. And basically what we did is we were aware that there were these multiple factors that would be important in any arrhythmia and causing any arrhythmia. So what we did is we designed a stepwise model in which our first group was like anesthesia. We just would put an animal on anesthesia for 4 hours. The second group we said, okay, we'll have anesthesia for 4 hours, and then we'll have anesthesia and a thoracotomy. And then we have anesthesia, thoracotomy, and pericardotomy. And then we have an atriotomy added onto that. And then we would have cardiopulmonary bypass added onto that. And first we'd do these all in normal tissue, and then we would do them all in models of various types of atrial pathology, like mitral valve incompetence, where you get enlarged left atria, or tricuspid valve regurgitation, where you also get an enlarged right atria. So for this particular study, though, we focused on 4 groups. Anesthesia only, anesthesia and a pericardotomy, and that also included the thoracotomy, because obviously they had to open the chest to do that. Anesthesia, pericardotomy, and an atriotomy. We put an incision in the right atria, because one of the things that's done in a lot of cases, an incision is made to put a cannula in if you're going to do cardiopulmonary bypass. And then anesthesia, pericardotomy, atriotomy, and then we treated it with a steroid, prednisolone. And this is a very big dose based on the veterinary literature. This should give you about as complete immune suppression as you can get in an animal with steroids. Preoperatively, we did Holters the day before, 24-hour Holter monitoring. This is a dynamic ECG recording. We measured C-reactive protein levels, and then on the operative day, we did an electrophysiologic study, and I'll tell you about that. We did our procedure then on this day, and then on postoperative day 2, we brought the animals back, did the electrophysiologic study, got tissue to quantify atrial inflammation by doing peroxidase assays, and then did a study looking at histology of the tissue. So just to give you a kind of a brief rundown, and I'm not going to give all the results of this study because it would take a long time, but I'll try to give you the highlights of what's important, I think. In our electrophysiologic studies, we did mapping. We put a system of electrodes on the atria that covered both the left and right atria that had about 250 electrodes. We mapped normal sinus rhythm, we mapped pacing, and then we mapped any induced atrial fibrillation. We would try to induce atrial fibrillation with an S1, S2, or a burst. We measured sino-atrial conduction times, sinus node recovery times. We gave drug challenges where we gave isoproterenol and adenosine, and we gave isoproterenol and adenosine together. We did blockade studies with esmolol and atropine on postoperative day 2, and then we also measured refractory period. Just for brief, we didn't see much difference in either of these 2 variables, and there was no relationship between the groups in any of these drug challenges or in the atropine. The only interesting thing was on the drug challenges, in the group that had steroids, isoproterenol killed the dog, so that part of the study was dropped. The cause of ventricular fibrillation in the first 2 dogs we did, so we didn't feel that lucky to go to the 3rd dog, so we quit doing that particular portion in that arm. And what we did, we're going to focus on looking at just a subset of these 256 electrodes. And this is a subset of, I guess, 35, 6x6 with one missing here, of electrodes that we did over the right atrium. All the analysis on our group is going to be from this area of tissue. We wanted to have the same area of tissue that we looked at in all groups. And because we had our atriotomy here, we wanted to also do our normal data on this tissue, our pericardotomy data from this same set of tissue. And you can't see it from this this particular square of the electrode, but this is part of an electrode patch that's form-fitting and sits on the atrium, so we were able to get some reproducibility of placement, so we always got our electrodes basically in the same place. And we made this atriotomy, when we made this, without going on cardiopulmonary bypass. We have a little tricky technique that I can tell you about later, in which we can stick a needle under here and run a wire through and put a suture underneath the wire and then use a bovie and just cut through the tissue. So we're able to make the incision without having to go on any cardiopulmonary bypass and not have any bleeding from it. We quantify inhomogeneity of conduction using a technique that some of you may or may not be aware of, the technique by Lemaire's and then with the Elisi group, in which what they did is they looked at all the activation times here, and here's an activation map, you can't see it very well. They took a section of this, and they looked at the maximum difference between any of these four electrodes, called that the phase difference. The maximum difference here is 18. This one is 4, this one's 3. They then did this for all the different points on their electrode array where they mapped. In our case, it was for that 6x6 array. And then they did a histogram. They looked at the 5 percentile point, the 95 percentile point, and then the median. They looked at the difference between these two and divided it, and that gave them an index of the inhomogeneity. And I'll show you an example of it if you really don't understand this technique, of how it works. The other thing, as I mentioned earlier, to quantify the inflammation from that area where we mapped, we got some tissue and we mapped, we measured the myeloperoxidase activity, which is a kind of a local measure of inflammation. Another measure we made is we also had a histologist blinded to the tissue do a score on the intensity and extent of neutrophil invasion of that tissue. And here are some of the results. Here's the C-reactive protein levels on the preoperative day, the operative day, postoperative day 1, and postoperative day 2. And then you see a small, but actually was a statistically significant jump with the first day with anesthesia that returned virtually to normal by postoperative day 1 and had leveled off by postoperative day 2. The second group, our pericardotomy group here, is this blue line that goes right here, and that was elevated, significantly elevated, and then started to go down on postoperative day 1 and 2. The third group, our atriotomy group, as you can see, went up higher and started to decay. And finally, our prednisolone group, there was a small bump here, which then went down and was returning to near normal. So although we tried to get immune suppression, we did not get complete immune suppression, but we got pretty close to it. Other studies in animals that have looked at C-reactive protein levels in animals showed that by postoperative day 5, it was pretty close to baseline levels. So that, again, it follows the time course that we see in patients with postoperative atrial fibrillation. So what were the effects on heart rate? They were actually very dramatic. This is results from Holter monitors. And here you see the typical heart rate trend of a dog. Dogs have this incredibly robust heart rate control system where they'll go from 60 beats a minute up to 150. And this is a very typical one and shows a lot of variability. And you can see here the same dog in postoperative day 1, there's virtually no variability. So there's a dramatic decrease in heart rate variability. And here's a histogram of the same data. What you see here is you lose this whole tail of these slow heart rates, and actually the maximum is down a little bit here, and you can see that when you go to the postoperative day 1, it's a narrow spike. You can, one measure of heart rate variability, we did the complete heart rate variability type of analysis, and I'm not going to go into that in this talk, I'm just going to tell you about one parameter, and that is something called the triangular index, which is the integral under this curve divided by the peak. And you can see, obviously this peak is much harder, these are different scales, and so we measured the triangular index as a measure of heart rate variability, and you can see, again, over time what happened. With just anesthesia alone, there was very little effect. It was back to controlled levels by, again, pre-op, operative day, postoperative day 1, postoperative day 2. It's back to normal levels. In our pericardotomy group, you can see that it went down. It was down fairly significant at postoperative day 2. In our atriotomy group, it went way down. It was down very low levels still at postoperative day 2. With our steroid group, the blue group here, it was actually higher in the control conditions because we gave these steroids a week prior to immunosuppress the animal, a week prior to doing even our first Holter. So there's an increased variability which diminishes somewhat and goes down with by postoperative day 2. One of the interesting things is we had on day 3, the postoperative day 2, when we sacrificed the animal, we also had the Holter from that day. And we looked at the triangular index for that day versus the local tissue, right atrial tissue myeloperoxidase activity. And there was a strong correlation suggesting that there is a relationship here, a positive relationship between inflammation and heart rate variability. So that was somewhat interesting. And one of the reasons we're looking at heart rate is we obviously want to see, are there going to be spontaneous events that are associated with this? And with disruption of the normal heart rate control system, will there be premature beats? Well, the rhythm analysis is a little difficult because this is a normal dog. This is not unusual. I mean, if you went to your doctor's office and this happened in there, you'd be in the unit about a half hour later. It's not unusual for dogs to have 5-second pauses just laying around. And in this case, there was actually a case of AV block, which probably occurred in a 24-hour period, maybe 20 times in a normal dog. So this was not an unusual thing. The other thing that makes the rhythm analysis a little complicated is this type of event. If you would present this type of ECG to a clinical cardiologist, he would call this a premature atrial beat because here you have a dramatic shortening of the P to P interval. However, this occurs all the time. And if we were to call these premature beats in a dog, first of all, they're very long intervals. We're talking about 500 milliseconds. Second, this occurs hundreds of times in a normal dog every day. So we had to kind of look at how we define things. So in the postoperative period, again, we saw pauses with rather long intervals and AV block. AV block now, and I'm not going to dwell on this, I just thought this was kind of interesting, now occurs hundreds of times a day in patients who are in the postoperative period instead of just maybe 20 times a day. And now we start to see active P that's at shorter intervals. And also, if you look at the P wave here, distinctly from other sites, there's also one here where you can see that the P wave is much different than the P wave under these conditions. So we see premature beats that are occurring at intervals that are less than 380 milliseconds and also are ectopic, that is, they come from a different site. Both of these would be considered certainly precursors and could serve as a trigger for atrial fibrillation. I didn't put it, I somehow lost the slide that I had sometime over the weekend while I was watching TV and putting this talk together. It must have been during one of the football games. I deleted my next slide, but I can tell you what the next slide is. I don't know where it went. But the next slide showed that we actually saw sharp runs of arrhythmias also in the postoperative period. They weren't sustained for very long periods of time, but for 3 or 4 seconds we'd get a run of supraventricular arrhythmias that were not, with no distinct P wave, but appeared to be fibrillatory. If you look at the spontaneous events per day, I didn't put the error bars on this, but preoperatively in the anesthesia group, there are virtually none. So this suggests that anesthesia, which a lot of people have thought maybe was a risk factor for premature beats postoperatively, does not appear to be. Now, the type of anesthesia we use, we tried to simulate what's done in people today, and so we used an anesthesia regime that was very similar to what's done in humans, and we did not see the type of arrhythmias that you would expect just from anesthesia. So that was illuminating. In both the pericardotomy group, the atriotomy, and even the steroid group, we saw a lot, and there was a lot of variability in this data, and statistically, by the way, these are not different. They are different from these, but I didn't put that down on this chart. The interesting thing here is that steroids did not seem to suppress this ectopy. So it appears that the ectopic beat formation is non-inflammatory, is mediated by a non-inflammatory mechanism that doesn't really have anything to do with anesthesia. So let's look at conduction. This is where we found our most interesting results. This is a typical activation pattern we saw both in the anesthesia group, by the way. We also saw this type of thing in the control group, where you pace and you get a nice smooth waveform. There's nothing remarkable. In the pericardotomy group, where the heart was manipulated and exposed to air, you can see it becomes a little more irregular. In the atriotomy group, along the edge of the atriotomy, you see a really disrupted pattern. And what you would expect to see if you were, if this were just a perfect incision here and there was no injury to the tissue surrounding it, you would expect to see something like this. But this is what we saw. In the steroid-treated group, this is what we saw. We saw a dramatic normalization of the conduction pattern, very similar to what you would expect to see in the just having an incision here. Analysis of this tissue, one of the things we looked at is whether or not there were a lot of dead cells in here, and is this a result of a lot of dead cells? And no, the cells here were all viable cells. There was no evidence that there was a lot of necrosis outside the immediate region of the cut here, right along the edge. So steroids appeared to normalize the conduction. So we quantified that because that's a very qualitative anecdotal type of data. We went to this technique where we calculated the distribution of the phase differences, and we did that for all 3 groups. Here's a preoperative control. You can see what the spread is. The anesthesia group's not much different. Pericardotomy group, it starts to spread out. The atriotomy group, it starts to spread out really dramatically. And if you look at the steroid group, this is what we saw. We saw a renormalization that was very similar to the normal conditions. And if you actually calculate this and calculate the index, the pre-op and the anesthesia were right around 1. By the way, 1 I don't think is a magic number here. I think it depends, this number, the phase differences, depends upon your electrode resolutions, how many electrodes you have, but it serves as a control value, so it just happens to be right around 1. In the anesthesia, it had virtually no effect. With the pericardotomy group, there was an increase. With the atriotomy group, there was even more of an increase. And with the steroid group, there was not a complete normalization, but very close to normalization. Even though it was not different than the anesthesia group, I think with a greater sample size, we might show that there still is some difference there. In this study, there was no difference. So it normalized it. And if you looked at the mild peroxidase activity, this is what the level was in the anesthesia group. Pericardotomy group, it went up. Atriotomy group, it went up even further, and it was normalized to the anesthesia level. And actually, this is about the same what you see in control tissue. Neutrophil index paralleled the myeloperoxidase activity as you would expect. Anesthesia group was very low. Pericarditis group increased. Atrial group increased even more, and was normalized. And something that was, I thought, really interesting, and again is evidence for a causative effect, is if you looked at all the data, the myeloperoxidase activity versus its inhomogeneity index, there was a proportional increase with increasing inflammation. That was a fairly good, strong relationship here, a correlation coefficient of 0.851, positive correlation between that and the myeloperoxidase activity. Not quite as good with the neutrophil cell infiltration index, which is a little more qualitative. So I'm somewhat not surprised because this is obviously going to be affected by observer bias, and it's not as an exact technique, but still had a very strong correlation. So what happens with refractory period? Refractory period gets a lot more complicated. First of all, we were only able to measure the refractory period at one point. We measured it in the right atrium, and preoperatively what we saw here is we got basic drive rates that went from right around whatever the refractory period was, near down here 120, 130, all the way up to 300. And you can see preoperatively, this is the control curve for the anesthesia group. Postoperatively, there was a slight decrease. So it appears that anesthesia does have a lasting and statistically significant effect even at postoperative day 2, even though most of the other effects of anesthesia seem to be worn off. So there seems to be a component of changes in the refractory period that's reflected in the ERP data. With the pericardotomy group, this was our pre-op data and our post-op data. They were overlayable, and there was, even though by a repeated measures analysis variance of 0.09, clearly there was not very much difference there. And it appears when you look at the atriotomy group that there's offsetting events going here. Here we have a lowering, and now if you look at the atriotomy group, this is the pre-op data, you can see that increases post-operatively. So I suspect what's going on here is we have the offsetting effects of these two. We don't have enough inflammation to rise it above the preoperative level and offset the effects of the anesthesia. Here we had a rather dramatic effect. In the steroid group, you can see that several things changed. First of all, preoperatively, the refractory periods are shorter, the adaptation curve is flatter, and in the postoperative group, there's still an increase, but the increase is only at the, it's actually, if you did a point-by-point comparison, the statistically significant increase is only down in here, whereas above about 200 milliseconds, this was not statistically different. So it appears that there's a combination of effects going on in the refractory period. We have effects of the anesthesia, we have effects of the inflammation and the steroids themselves, and there's probably some other non-inflammatory mechanisms involved in the refractory period. Now this is the refractory period at one point. What do we know about refractory periods over the whole atrium? Well, we mapped all 250 points on the atrium, and in about half the animals, we're able to induce a non-sustained run of atrial fibrillation. And what we did is we looked at the frequency of activation at each electrode site. And then we looked at the variability of that frequency over the atrium by calculating the standard deviations of all the frequencies from all over the heart. And in the anesthesia group, this was our standard deviation of our frequencies. It increased in the pericardotomy group, was even more increased in the atriotomy group, and normalized here. I would like to suggest that this is indirect evidence that this is representing an increase in the inhomogeneity or refractiness over the atrium, and that it's normalized by steroids. I think this is something we still need to develop, obviously, a lot more. And one of the next steps in our research is to actually go in and measure refractory periods over a large number of sites to show whether or not this is really reflective of an inhomogeneity or refractoriness. AF inducibility. Using pacing to induce these animals in the atrial fibrillation, we saw a biphasic response. In about half animals, we could always get a few seconds or up to maybe 15 or 20 seconds of atrial fibrillation. But only as we had an increase in inflammation did we get sustained atrial fibrillation. And I'm calling sustained here over 3 minutes. If we went over 3 minutes, we quit timing. I wish we would have timed it out and been more patient and sat there and actually get the total duration. But and we quit timing after 3 minutes. We won't make that mistake again. We'll follow it all the way out. But if you see a very discrete dichotomy here between the two groups of non-sustained and sustained events, and if you look at the myeloperoxidase activity, the ability to induce atrial fibrillation went up with the inflammation. So what I'd like to kind of give you what our conceptual model is of what's going on here. In a normal slab of atrial tissue here, you have, if you pace it, you get a spread of beads in a very radial or elliptical fashion, depending upon the tissue fiber orientation. And we hypothesize that there is a non-uniform inflammatory response in the tissue, and that with this non-inflammatory response, that there's going to be release of various factors, and we don't know what those factors are: cytokines, platelet activating factor. There's a whole laundry list of these that are being released in some non-homogeneous fashion over the course of over the atrial surface. And what that gives you then is this irregular pattern of conduction. We'd like to also further hypothesize not only that we have this non-homogeneous inflammation, conduction, but we're also hypothesizing that it's probably having a similar effect on the refractory period, and there's a non-homogeneous pattern of refractoriness that contributes both to the initiation and the maintenance of atrial fibrillation, along with the slowing of conduction that occurs. So, as I told you before, I'm going to follow, kind of start in a very clinical path, and I want to kind of finish with the clinical path. How can we use anything we learned here to treat atrial fibrillation? I've already told you can't go around giving massive doses of steroids to patients. We're not going to let you do that. But one of the things that I think has an interesting bioengineering twist to it, some of you people may be interested in, several companies have approached us now with biogels that are kind of sticky. One of them calls it shrink wrap for the heart, that you can put these biogels over the atria and then have controlled drug release. So we're actually looking right now, talking with Medtronics and a small startup company called Kinsey Nash that makes this biogel. And what we'd like to do is dope it with steroids, where we can give a local delivery of steroids and not have all the systemic effects. These biogels degrade within about a week, and that would certainly get us past this period of time. So one of the therapies we hope to look at potentially in our animal model is, can we normalize this by not giving massive doses of steroids, but giving some directed drug delivery. And so that's where we're off to in the future. And not to keep you guys out too late, I wanted to thank all the people who actually did all the work. Yosuke Ishii, one of our fellows who's back in Japan, was absolute marvelous scientist. Kiyomi Yamada, I guess one of Catherine's sisters or something. I was going to say her daughter, but I won't do that to her. her sister did all the histology for her. She was blind, and she was generous enough to do that. Sidney Gaynor helped Yosuke in all these complicated animal care issues and surgery. We did a lot of things we didn't tell you about in the story, but we actually even marked on the Holter every time we gave pen medication to see what the effects of pain medication were on all these heart rate parameters, which is a whole other talk. And then one of the biomedical engineering students, Annabelle Fu and Julian Kagi, Julian was a undergraduate in biology. They literally looked through 4 days of Holter recordings on each of these dogs. And each day you get about 100,000 beats. So they edited and checked all the beats, and it just did a tremendous amount of work. And then my mentors and spiritual leaders, Ralph Damiano and John Moreno, gave a lot of heckling from the sidelines and good advice. Thank you very much.
Thank you, Rick. And open for questions and discussion. I have to apologize because I have to run to another meeting, but you can ask me any question you want.
Right.
Thank you.
Yeah, thanks for having me.
How do you measure impurity? NPO, mild peroxidase?
Oh, mild peroxidase activity? Actually, I don't have the paper with me. There was an assay. I apologize for not having the assay on the top of my head. I don't remember. It was Yoski did it. It was a standard technique that was actually used by one of the other groups in our lab who does a lot of inflammation work in the lung. And I apologize. If you go to the reference, it'll detail it for you. It was a standard assay, mild peroxidase assay.
No, several of them.
The C-reactive assay, the C-reactive protein was done with an ELISA kit that comes from Ireland, of all places. I don't know why the Irish, but they call you. It's amazing. You can call them, and they'll call you back, and they're very helpful. It turns out C-reactive protein in dogs and pigs is very big in the veterinary business. Igor?
So, can you briefly outline what is the difference between this model and model which number of groups studied for years with this sterile
pericarditis model? I think the sterile pericarditis model has given us a lot of insight. The problem was it's not a very controllable model. In addition, there's a lot of cell necrosis. This is a massive insult. And one of the things that we wanted to try and do is, first of all, be able to sort out different effects, but we also wanted to have be able to see some, like a dose response or a proportional response where we can kind of control inflammation to a degree so that we give a little bit of inflammation, a lot of inflammation, and increasing degrees of inflammation to see if the changes in electrophysiology were proportional. So I think there's a lot to be learned in that model. Also, that model gives you just a lot of flutter. It doesn't give you much.
So if I remember correctly, in this model in sterile pericarditis, you have essentially peak. First it goes into AF and then into flutter.
Right.
And pretty much would stay there.
Yeah. And if you give steroids, by the way, it goes from flutter back to the fibrillation. So I don't know what that means. I guess it's because insurance are refractory to this. But I thought that's an interesting model. And actually, the person who worked with that originally with Al Waldo, who is most famous for that model, was Pierre Paget, who's a surgeon. And what they do is, for those of you who don't know what the model is you open the pericardium and you throw talc in. Talcum powder, just throw it in. And of course, it elicits an enormous response. And, there's a lot of cell necrosis, and that's what we wanted to avoid. And we also wanted to have some proportional response.
Well, it was probably even before that, Claude Beck did the same thing to humans and put asbestos powder.
Yeah. Well, if you want to go back, there's all these people in the surgery business who had all these ideas about trying to cause neovascularization by putting phenol on the heart, and actually did some people, believe it or not. A guy named Dwight Harkin in the 50s actually did a study in animals where he thought he saw neovascularization by covering the heart with phenol and wiping it off. And he actually did this in patients, and patients had a complete obliteration of all their pain, which people got all excited about. And they attributed it to neovascularization, and it turned out to be denervation, of course, because we now know that the easiest way to denervate the heart is to cover it with phenol. So, yeah, I'm sorry.
Do you have any data about the size and the length of the atriotomy?
Yeah, the atriotomy we have here was a standard atriotomy. We made it in what we felt was a very reproducible manner. We started at the tip of the atrial appendage. We paralleled the crista terminalis for 5 centimeters, and we avoided the sinus node artery. And because what we didn't want is big areas of ischemic dead tissue. We didn't want to come back and find a big right atrial lymph. You see that, by the way, when you do lots of congenital surgery. You bring kids back years later who have lots of arrhythmias, and their posterior right atrium is all dead. It's just a big, massive inflow. We probably would have seen more spontaneous events. Some years ago, we did a study in which we were trying to simulate what goes on in post-Fontan arrhythmias. Kids who have a particular operation called the Fontan procedure have a lot of arrhythmias as they get older, particularly atrial flutter. And so we felt that part of it was, and this occurred even if the tunnel, they call it, was put external. And we said, well, maybe it's just the suture lines themselves that are providing the substrate. So we ran a suture line right along the crista terminalis that actually involved the sinus node, because that was also one of the other things. We were actually trying to look at sinus node dysfunction. And all these animals had flutter. In fact, of the 6 animals we survived, 2 of them were in continuous flutter. And they had huge amounts of atrial premature beats. There was no question of that. Plus, they all had flutter. So I think our avoidance and the fact that our sinus node recovery time, our sinoatrial conduction times were all normal suggests that we probably protected the node a little too much. If we would have kind of got up there and damaged the node, we probably would have saw a lot more spontaneous events. And that's actually kind of on the table as another protocol to deliberately damage the node and see if that results in a lot more spontaneous events.
How much swelling do you actually get with some of the procedures, and how much of maybe stretch-induced channel activation is responsible, and what's the time course for that kind of injury?
That's a good question, and we haven't measured, and that's probably something we should measure. Just grossly, there did not appear to be a lot of swelling. Histology of the tissue did not show a lot of, interstitial edema pushing some. I'm sure there's some, and probably when you get right next to the incision, it's probably at its greatest. But we did not really evaluate that in any significant way. I will tell you that probably in these cases, the hemodynamics on these animals were similar. I doubt if the atrial pressures were significantly different than they were in the preoperative period. We didn't do anything that I think altered that in any significant way. Obviously, it's not exactly the same, but it was a minor factor. But edema is something that potentially could be a huge thing. Now, what you would expect, though, is if you had a really edematous tissue, you would expect possibly an increase in conduction. So when we saw slowing in conduction, we didn't really suspect edema as being one of the major factors in the slowing.
But the thing is, you revise these animals on post-op day number 2.
Right.
So, edema should be kind of subsiding by then.
You probably know that better. I don't know. What's the time course post-surgical?
First day, you would have edema, but second day, it would subside a whole lot more than initially you saw.
Thank you for your answer. Yes?
So the steroid, is that standard anti-inflammatory?
Yeah, prednisolone. Yeah. It's particularly commonly used in veterinary practice. And I don't know, is this one you use clinically ever?
Prednisolone?
Yeah.
It's used,
Yeah. So, the peanut gallery up here.
Not a non-usual dose. That's a
This dose is not a dose you would ever give to a patient or probably even to an animal. It's a massive dose, and it's made to suppress the immune system as much as we can. Yeah, this is just an enormous dose. Any other questions?
I have a very simple question. What's odds ratio? What's odds ratio?
Odds ratio. Oh, that's a statistics question. Odds ratio. Simply put, it's the ratio of the increased risk of a event versus a control event. So patients who have nothing pre-op, post-op have an event. It's the relative risk, the ratio of the relative risk. That's pretty good. You ought to go Google odds ratio. I actually did that the other day because somebody asked me about odds ratio. I want to make sure that that's an assignment. Yes.
So I had a question here. He's shy to ask. So why do you have atrial fibrillation but not ventricular fibrillation?
What is it?
So is there any difference?
Well,
we
had no spontaneous ventricular fibrillation, but we did have spontaneous ventricular premature beats. We had a rather significant number. Fortunately, we didn't have any ventricular fibrillation, except when we used in the steroid group when we gave bisoprolol, and they all fibrillated. So he actually, to give you a little more, it actually went into a tachycardia first, that then degenerated. So it actually caused a ventricular tachycardia to be more precise, that then caused hemodynamic collapse, and then we went into fibrillation. But that's not an experiment we want to repeat too many times. If you want to, you're more than welcome to try it. I don't know. clinically, I wish one of the clinical electrophysiologists were here because I was kind of surprised because I had never read this before. That in patient, I've never heard that patients, for instance, that are in steroid treatment, like heart transplant patients, are more susceptible to spontaneous ventricular arrhythmias if you give them a beta stimulant. Anybody managing, any of you guys managing transplant patients ever seen that happen?
We don't typically give them beta stimulant.
No, unless they're hemodynamically compromised, and you know.
Yeah, I mean, if you gave, I don't know if dobutamine would give you the same thing, but
And it's similar.
Yeah.
It's not selective action as opposed to isoproternol. I mean, isoproternol is not selective. Same thing as
no, it's beta.
You know, so I mean, they still give it to them, but I don't know. Look that up. See if there's an increased incidence of defect.
So I'll let you go. We got one
Just
here.
a very quick question. So you measured at one point refractory period. So why didn't you measure something like monophasic action potential?
That's a good question.
Probably
And
easier.
I think that's something we talked about.
Or even optical, maybe.
I guess, yeah, well, I can tell you why we didn't do optical. Because, you know, it so messes up the calcium currents that, I mean, I don't know what effect, what the data would mean. The monophasic action potential, we actually thought about doing that, and it's been suggested by other people too. And we probably should have done an initial study because it would have been so easy to give us some insight. But there's always so much controversy when you talk about monophasic action potentials, you know. I guess I'm gun shy about whether or not that accurately reflects the repolarization process or not. And refractory period is the parameter we want to know. If the action potential is not following the refractory period, it's the refractory period decides whether or not a wavefront is going to block or not.
Rick, did you use propranolol you studied? Propranolol and Nadolol, did you
Yeah,
use?
I didn't tell you about that. There were some interesting results of that. That's a whole, kind of the heart rate variability and the heart rate stuff was very interesting with the esmolol and the atropine, and we did a combination of esmolol and atropine and looked at how the heart rates changed and stuff like that. Just let me give you one conclusion. With combined blockade of both the sympathetic and parasympathetic system, in the most inflamed group, the atriotomy group, there was no change in heart rate, whereas in the control type groups like anesthesia, where there was very little inflammation, there was a dramatic increase because the animals were very vagal. So as the animals became more inflamed, they became less vagal, and there seemed to be a balance. And obviously, too, when you gave, you know, the high frequency component of the heart rate variability went to 0 with atropine, and clearly the low frequency is not a measure of sympathetic tone because when you gave esmolol and atropine and the combinations of the two, it went down with all of them. So there's clearly a lot of sympathetic components in that. But we did a whole heart, and I'm sorry I didn't want to draw that out. Also, that data is, there's some controversy with all that data means about heart rate variability. I just wanted to give you some idea of what was just happening generally with heart rate with the inflammatory process. And the fact that there was a correlation as you got more inflamed, the variability went down. Any other questions? Thank you again. Before we go, I also want to thank two other people. I've been writing a grant up on this, and Catherine Yamada and Jean Earbone have been really helpful in helping me think about this problem, the next steps we're going to do. Hopefully next time I come back and talk, we'll be talking about what I'm doing in my R01 to answer a lot of the questions that came out of this. Thank you very much.